Hello, everyone. Uh, my name is Anastasia, and this is Sankalp, and we're cardiothoracic anesthesiologists from the BI DMC. We're going to talk today about perioperative right ventricular dysfunction. In 1943, the right ventricle was considered to be a little more than a passive conduit for blood. Starring William cauterized with warm iron dug right ventricles and did not find any hemodynamic significance. So it was assumed that its importance was not great as it pumps blood to only one organ, the lungs. During 1950s, cardiac surgery teams began to understand the importance of the right ventricle as they attempted to develop techniques for palliation of right heart hypoplasia. The crucial role of the right ventricle is now very well understood and recognized in a wide variety of cardiac and non-cardiac conditions. During the past decade, there has been intense interest in this area with expanded treatment options and enhanced outcomes in patients with acute and chronic disorders of the right side of the heart. Novel imaging techniques, advanced surgical approaches, enhanced understanding of the right ventricular infraction ischemia, intense physiological investigation of the right-sided hemodynamic and ventricular independence, advanced pharmacology for managing pulmonary hypertension. There have been advances in both diagnostic techniques and durable and temporary mechanical circulatory devices. However, still there are no available guidelines for perioperative management of the right heart failure. I'm going to start the presentation with three clinical scenarios that we have encountered. The first scenario, 65-year-old female with past medical history of osteoarthritis and obesity presents for elective hip replacement. She has not visited her PCP for 3 years, and physical exam in the preoperative clinic shows bilateral pitting edema. Second case is a 73-year-old male with history of right ventricular failure and COPD who presented in the GI unit for a screening colonoscopy. He complained from shortness of breath shortness of breath with minimal exertion. He had MET status less than 4, and accidentally he received 1 liter of crystalloid after the IV placement. The third case scenario is a 53-year-old male who presented in the emergency department with angina. He was diagnosed with acute coronary syndrome due to occlusion of his RCA. The echo showed hypokinesis of the right ventricle, and the cardiac catheterization showed multivessel disease. Currently, the patient was in the ICU with cardiogenic shock. He was referred for a CABG. In order to be able to identify, diagnose, and treat right heart failure in the perioperative setting, we have to understand the right ventricular anatomy and physiology. As we see, right ventricular dysfunction presents with diverse clinical scenarios. The right ventricle is composed of 2 layers of muscular fibers, superficial circular fibers, and continuous with the subepicardial fibers of the LV and the deeper longitudinal fibers. The RV is a smaller ventricle than the LV, has a thinner wall. It's a crescent shape in the cross section, has a complex geometry, and it's wrapped around the thicker symmetric bullet-shaped LV. Talking about the RV, we need to mention that it's relatively resistant to ischemia. It receives dual supply from the right and the left coronary system. And unlike the LV, the perfusion of the RV occurs during both systole and diastole, providing the myocardium with oxygen throughout the cardiac cycle. This phenomenon occurs only in healthy patients, only healthy hearts, and in the disease state, such as patients with pulmonary hypertension, increased intracavitary pressure during systole is going to mean that the ventricle is more dependent on perfusion during the diastole, similar to the LV. The basics of the right ventricular physiology include the basic concepts include that's a high volume, low pressure pump. It's compliant with a high capacitance since it pumps into the pulmonary vasculature, which is a low resistance system. Its afterload depends on several factors, and perioperatively it's anesthesia dependent. And there is an important ventricular interdependence between the RV and LV. The contractile function of the RV generates 1/6 of the LV work and the pressure, and the pulmonary vascular resistance is only about 15% of the systemic vascular resistance. As a result, the RV adapts better to the volume than pressure overload. Recently, there have been advances in the right ventricular pathophysiology understanding, and let's go through some examples. The concept of the right ventricular peripheral circulation coupling is described on the first slide, and the coupling describes the energy transfer between the ventricular contractility and the arterial afterload. The ventricular contractility is well characterized by the end systolic elastance, a load-independent measure of systolic function. The ratio of the end systolic elastance with the effective arterial elastance is usually preserved in normal hearts, and it's more than 1.5. And we see that during early phases of right ventricular dysfunction, it can be maintained secondary to the RV being hypertrophied, and that's a compensatory mechanism. However, as the RV failure progresses, this ratio decreases. On the second slide, we can see that as the heart rate progresses, as the heart dysfunction progresses, and patients with pulmonary hypertension, the mean pulmonary arterial pressure to cardiac output ratio starts becoming smaller. And that's a ratio that's age and sex independent. It's predictor of mortality. And we can see that patients with pulmonary artery hypertension have a high slope, and they're being found to be significantly older with cardiopulmonary comorbidities, worse resting hemodynamics, and higher pronatriuretic peptide. Those are markers, prognostic markers that have been identified in pulmonary arterial hypertension, along with the regional longitudinal strain. Finally, on the under this CMD, we can see molecular markers that are important in an adaptive remodeling, and have been identified. Factors have been identified such as vascular changes, metabolic switch, inflammation, apoptosis, and fibrosis. We can see that the RV phenotype progresses from RV enlargement to uncoupling and decreased DAPC, as well as low right ventricular stroke volume eventually. Another important concept is the ventricular interdependence, as already mentioned in the RV failure. Normally during inspiration, the septum is moving towards the left ventricle, and during expiration towards the right ventricle. With ventricular interdependence in the right ventricular failure, there's dilation of the RV, which shifts the interventricular septum towards the LV. The geometry is affected, and that's the first sign of right ventricular failure. Acute RV distension may also lead to an increase in the pericardial constraint, as we can see here from the arrows. These changes eventually contribute to a low cardiac output state by decreasing the LV distensibility, the preload, and the ventricular elastance. In general, as mentioned again, the RV adapts better to volume overload than pressure overload. Talking about the pathophysiology, we have to mention that the pathophysiology of the right ventricular failure is almost vicious cycle. And in this scene, we can see figure helps us understand how the causes and manifestations of the right ventricular heart failure are closely correlated. The right ventricular dysfunction can start or result with pressure or volume overload, an MI or congenital defect, which can lead to myocardial injury or stress of the RV, which eventually leads again to right ventricular dysfunction. Right ventricular dysfunction can be systolic dysfunction or diastolic dysfunction, and it can affect the ventricular interdependence. With the systolic dysfunction, we eventually have low cardiac output, which and arrhythmias or tricuspid regurgitation can contribute to the low cardiac output, and eventually this can lead to circulatory failure or myocardial infarction. Respectively, diastolic dysfunction can present with edema, congestive hepatopathy, deteriorate the right to left shunt if there is a PFO, and lead to hypoxemia. But how can we discriminate if the right ventricular heart failure is compensated or decompensated? So right ventricular heart failure is a clinical syndrome resulting from the right heart's inability to provide adequate blood flow to the pulmonary circulation at the normal CVP. At the initial stages of the RV dysfunction, it is compensated, and as it progresses, we can see manifestations of early and late right ventricular heart failure, such as drop in the stroke volume, increase in the pulmonary vascular resistance, fall in the decrease in the cardiac output, and dissociation of the ventricular arterial coupling. Increased pulmonary vascular resistance has been identified as a cause of mortality in cardiac surgical cases and as a significant cause of mortality in patients who undergo non-cardiac surgery. Let's talk a little bit about the causes of right heart failure. It can be decreased RV contractility. It can be factors that contribute to decreased RV contractility, RV volume overload, or RV pressure overload. For example, right ventricular cardiomyopathy and ventricular infarct are causes of decreased RV contractility. The tricuspid regurgitation, pulmonic insufficiency can be causes of right ventricular volume overload. Pulmonary embolism, left valvular disease, pulmonary hypertension, ARDS can be causes of right ventricular pressure overload. Finally, sepsis and post-transplantation can be causes of right heart failure, both for decreased conductivity and pressure overload. Congenital diseases can be causes that are having manifestations of decreased contractility, volume or pressure overload, and shunts can be either pressure overload or volume overload conditions. Regarding the morbidity and survival of perioperative right heart failure, a recent study from a single tertiary institution analyzed data from 2011 to 2015, and they found that major causes of the incidence of right heart failure has been secondary to most commonly left-sided heart disease, lung disease or hypoxia. Pulmonary arterial hypertension was one of the major factors, and pulmonary thromboembolic disease was another cause of right heart failure. And as we can see with this Kaplan-Meier curve that they presented, again, pulmonary arterial hypertension, pulmonary thromboembolic disease, left-sided heart disease, and lung disease or hypoxia were major causes of mortality for those patients presenting perioperatively. Since pulmonary hypertension is a significant factor for right ventricular failure, I'd like to briefly mention the grading of the pulmonary hypertension, which has been changed recently, and now we classify as mild pulmonary hypertension a pressure, mean pulmonary artery pressure less than 20 millimeters of mercury, moderate 20 to 40, and severe more than 40 millimeters of mercury. And then WHO classification includes Group 1, which is patients with pulmonary arterial hypertension, Group 2, resulting from left heart disease, Group 3, underlying lung disease contributing to pulmonary hypertension, Group 4 has been the patients with chronic thromboembolic events that lead to pulmonary hypertension, and Group 5, it's uncertain etiology. There's no guidelines available for risk stratification perioperatively. However, they have been suggested, some helpful recommendations have been suggested. The symptoms of the RV failure are not specific, present with progressive dyspnea most frequently, and we can see signs of jugular venous pressure, peripheral edema, and hepatomegaly. I will present now the recommendations for stratifying the patients perioperatively. We divide the patients in stage A category, which are the patients who present with no symptoms and no structural changes. Those are the patients who have early pulmonary hypertension, left ventricular or valvular dysfunctions, familial history of right ventricular failure, patients who have been exposed to cardiotoxins or atherosclerotic changes. Stage B are still patients with no symptoms, but they have some structural changes already, such as pulmonary hypertension, early stages, congenital heart disease, left heart failure, prior MI of the right ventricle, tricuspid valve or pulmonic valve changes. In stage 3, we see patients with prior symptoms of right heart failure or current symptoms. Those are patients who have structural heart disease manifestations, right ventricular dysfunction. They can present with fluid retention, fatigue, palpitations, and usually have METs less than 4. And stage D, which along with stage C are the chronic right ventricular heart failure patients, are the patients who have refractory right ventricular failure requiring intervention. Those are patients with symptoms at rest despite treatment and refractory arrhythmias. What we can do for those patients perioperatively, for the stage A, we are required to keep a close eye, close monitoring. Stage B, the recommendations are to consider beta blockers, ACE inhibitors, medication treatment or surgery, and defibrillators. For stage 3, all previous apply, plus they are considered to be good candidates for diuretics, digoxin, cardioversion, or RV synchronization. And finally, stage 4 are all the previous measures apply, plus we should be very alerted for optimization, inotropes, mechanical support, or at the point where we can introduce end-of-life discussions. And at this point, I'm going to stop and pass along the presentation to my colleague, who's going to talk about the perioperative assessment and treatment.
Thank you, Anastasia, for that wonderful introduction to the right ventricle, the pathophysiology of right ventricular failure, the etiology, such an important topic. I'm going to continue here, everyone. To reintroduce myself, my name is Sankalp. I'm also one of the cardiac anesthesia attendings here at Beth Israel Deaconess Medical Center. So let's start with the perioperative right ventricular dysfunction assessment using echocardiography. So we now know by advanced cardiac deformation imaging that volume changes in the right ventricle, they occur along 3 axes: the longitudinal, the radial axis, and the anteroposterior axis. The longitudinal contraction is the greater contributor to the right ventricular function and its effective stroke volume. And that is why you'll see that many of the echocardiographic quantification methods revolve around this longitudinal axis of right ventricular motion. This image here shows contribution of the three RV vectors motion that we talked about, the directions in healthy control and in disease state. So this is a patient that is otherwise healthy, and you can see there's a contribution on the bottom, the contribution from the longitudinal, the radial, and the anteroposterior motion of the right ventricle. This is a patient who has who's had a pulmonary embolism. There's a result in lower radial motion and a higher contribution of longitudinal motion in the overall right ventricular function. Next is a patient with right ventricular volume overload state, in the presence of a large atrial septal defect with a left to right shunt. And you can see that there's a much higher longitudinal component of right ventricular motion. And finally, here's an example of a patient with left ventricular dysfunction in a patient with heart failure, non-ischemic cardiomyopathy, but a maintained right ventricular systolic function. And you can notice a severely reduced anterior and AP and radial motion, whereas a compensatory increase in the longitudinal motion. So you can see how in different disease states with volume overload and pressure overload, the right ventricular motion adapts to changing pathophysiology. This is essential in understanding echocardiographic assessment because you want to know what to anticipate in abnormal or disease states. Now, besides the right ventricular anatomy and geometry that we talked about, it's also essential to understand the regional coronary supply, which my colleague touched base on, to determine the regional wall motion abnormalities during ischemia and right ventricular infarction. Now, the main supply to the right ventricle is via the right coronary artery from the PDA for the inferior, the basal, and the mid intraventricular septum. Next, the acute marginal branch, as shown here in pink, is the one that supplies the lateral and the anterior surfaces of the right ventricle. The conus branch supplies the right ventricular outflow tract. And finally, the left anterior descending supplies a small portion of the right ventricle, but an important one, which is the right ventricular apex. Let us now discuss some monoplane echocardiographic imaging, which is useful for right ventricular assessment. So this is the first on the apical four-chamber view. This is useful to measure the right ventricular shape, the size, and the right ventricular function using fractional area change, which we'll talk about next. Also, other functional assessment modalities such as TAPSE, tricuspid regurgitation velocity by jet assessment, and right ventricular strain can be assessed in this view. Next is the parasternal right ventricular long axis view. Here we can measure the right ventricle for enlargement and for wall thickness. And finally, parasternal right ventricular short axis view, you can see a crescent-shaped right ventricle, which can be appreciated here. And with the septal flattening and systole or diastole can be seen in disease states because of asymmetric contraction. Now, it is essential to understand that by using different imaging planes, we visualize different aspects of the complex right ventricular geometry. Just see here in the apical four-chamber view, we're looking at the lateral wall of the right ventricle. In the parasternal view, we're looking at the anterior wall of the right ventricle. And in the parasternal short axis view, we're looking at the inferior, the lateral, and the anterior aspect of the right ventricle. Again, this image here highlights that with different views, we're highlighting different areas of the right ventricle. So in the apical four-chamber view, we're looking at the lateral wall of the right ventricle. In the parasternal long axis view, the anterior. And in the parasternal short axis view, we're looking at the anterior, the lateral, and the inferior walls. So the right ventricle can be visualized on a standard apical four-chamber view as shown here. So you can see the right ventricular septal and the free wall. However, image acquisition of right ventricular focused four-chamber view is vital for its full delineation, especially for the right ventricular free wall. Here's an image of focused right ventricular view on the four-chamber on 2D and on 3D imaging. You can see that there's more detail laid on the right ventricular free wall and apex compared to routine four-chamber. Now, the most commonly used tool for quantitative right ventricular assessment is fractional area change. It is limited in representing the function of right ventricular free fall only in a single two-dimensional plane, but it is one of the more easily reproducible and one of the more feasible modalities. Here you can see examples of right ventricular fractional area change. Here on the left is a normal right ventricle with a fractional area change, or an FAC of 60%. In the middle here is a mild or moderate right ventricular dysfunction with a fractional area change of about 40%. And on the extreme right is a right ventricular dysfunction with severe dilation with a lowered fractional area change of only about 20%. So you can see how fractional area change helps determine the change in area of the ventricle, and it decreases with decreasing right ventricular function. Another quantification tool using echocardiography is called TAPSE, or tricuspid annular plane systolic excursion. It measures the descent of right ventricle base towards relatively fixed apex. So although it's a highly feasible and easy to perform calculation, it's highly reproducible. It is not affected by trabeculations. The problem with TAPSE is that it does refer to only that longitudinal motion of the right ventricular chamber. Now, I know we talked about this earlier when we talked about right ventricular motion and vectors in different planes, and we did talk that longitudinal motion is one of the most important motions. So TAPSE, with all regard, is actually a fairly accurate assessment of the right ventricular function in most disease states. Further, it's also highly dependent on loading conditions, so that's something to consider. That can change with both ventilation and atrial fibrillation. Next, the tricuspid annular motion for RV assessment can also be evaluated by using tissue Doppler. This also measures the longitudinal velocity of the tricuspid annulus as displayed in the image here. Now, to measure this parameter, the right ventricular focused view, as seen in this image, is used with tissue Doppler region of interest placed at the lateral corner of the tricuspid annulus, and then a velocity called the S prime is determined, which is the highest systolic velocity of the right ventricle. This modality, the tissue Doppler imaging, it's simple, it's rapid, high feasibility, but again, it's also primarily reflecting the longitudinal fibers of the right ventricle. Now, the development of cardiac deformation in recent years has provided a deeper evaluation of right ventricular function in various pathological conditions. Strain, which is defined as deformation of an object compared to its initial shape, is expressed as a percentage. It can assess intrinsic myocardial performance, unlike other echocardiographic parameters, which we talked about, like TAPSE and FAC, which are not intrinsic myocardial performance indicators and are more dependent on loading conditions. So longitudinal strain, as seen as in this image, is measured by 2D speckle Doppler, and is reliable and accurate way to measure right ventricular function. Finally, 3D echocardiographic imaging for right ventricular assessment has evolved over the last few years. And although it's less commonly used in routine clinical practice, it does help visualize the entire ventricle, the right ventricle, and re-slice it in short axis cuts. It eliminates the need for simple geometric model, and this has been validated against many CMR or cardiac MRI models for accuracy assessment. Now, here's an example of a comprehensive right ventricular functional assessment using multiple parameters that we just talked about. So you can see that in image A, B, and C, we see a normal right ventricle in which the TAPSE is a normal value of 2.8, a right ventricular S prime value of 14.4, and a normal right ventricular EF of about 57%. Image D and E here show reduced EF with a reduced fractional area change of 45%, and E is showing global longitudinal strain, a reduced strain of -10%, with the normal value being -18%. Here's another example that represents echocardiographic assessment and classification of patients with pulmonary hypertension in 3 risk groups based on ejection fraction and global area strain. This is a normal healthy control. You can see a normal EF of 50% and a global longitudinal strain of -39%. B is an adapted right ventricle with a slightly reduced EF of 41% and a near normal global longitudinal strain. Image C is an adapted remodeled right ventricle, which is dilated. It has a moderately reduced function of 27%. And a global longitudinal strain of negative 24%. And finally, an adversely remodeled ventricle, which is severely dilated with a severely reduced ejection fraction of about 18%. So this is how we assess and stratify RV dysfunction. Here's an echo video showing acute inferior wall myocardial infarction complicated with right ventricular MI causing reduced RV function. Here's another video demonstrating popularly called the McConnell sign in acute pulmonary embolism, in which the RV apical wall is hyperkinetic and the RV free wall is hypokinesis. So you can see how 2D echocardiographic assessment gives us a fairly good idea of RV function. Here you can see right ventricular dilation in an apical four-chamber and in the parasternal short axis view from chronic pulmonary hypertension. And finally, this image shows a D-shaped intraventricular septum. You can see the right ventricle here in the parasternal short axis view and the left ventricle here. This is again caused due to right ventricular dilation, severe dilation from pressure overload. Now that we understand echocardiographic assessment, let's talk briefly about the perioperative management of right ventricular dysfunction. The key to perioperative management in these patients is prevention, and this is threefold. First is individualized preoperative risk assessment. Second is optimization and advanced perioperative planning. And third is prevention of right ventricular failure. So prevention begins by individualized risk assessment, and this is using functional status such as the New York Heart Association classification, the 6-minute walk test, the peak oxygen uptake, etc. You can use biomarkers such as the brain natriuretic peptide or the NT-proBNP, imaging such as echocardiography that we talked about, cardiac MRI, and hemodynamics or right heart cath data such as the mean PA pressures, as my colleague talked about stratifying RV dysfunction, cardiac output, or pulmonary capillary wedge pressure. Using these parameters, patients can be categorized into low, intermediate, or high risk as outlined in this expert consensus guidelines. The next step to prevention is optimization and advanced perioperative planning. This includes optimization by modification or escalation of existing pulmonary hypertension medications, choosing a correct and appropriate surgical and anesthetic plan, the one that is least invasive, with minimizing changes in pulmonary vascular resistance and loading conditions, choosing invasive monitoring, such as invasive arterial blood pressure monitoring or central venous pressure or mixed venous pressure monitoring, planning multimodal postoperative pain control, which we can talk in more detail in another lecture, focusing on perioperative anticoagulation or preemptive pain control, more advanced therapies such as pulmonary endarterectomy, pulmonary angioplasty, for example, in patients who have chronic thromboembolic pulmonary hypertension, and also close postoperative monitoring. Finally, since most of the postoperative complications occur due to physiologic consequence of RV pressure overload and ventricular dysfunction, the final step of prevention is prevention of right ventricular failure. Now, these include a balanced anesthetic induction, limiting tachycardia, avoiding decrease in systemic vascular resistance, and adapting an RV protective ventilation. This uses small tidal volumes, 5 to 7 mils per kilogram, and a low P, avoiding high plateau pressures during mechanical ventilation, providing adequate analgesia, and using early extubation techniques. Next is maintaining right ventricular perfusion pressure and avoiding ischemia by raising your mean arterial pressure. And finally, by maintaining preload and avoiding hypervolemia. To sum up, one must continue uninterrupted pulmonary hypertension therapy perioperatively, reduce sympathetic stimulation by optimal analgesia, maintaining normothermia and adequate heart rate, lowering the PVR by providing supplemental oxygen, avoiding hypercarbia, adapting early extubation, Close monitoring for the first 24 to 48 hours post-operatively, including hemodynamics and some way of monitoring filling pressures, line filters for patient-driven intracardiac shunts, and using early mobilization and DVT prophylaxis techniques. Now, with regards to treatment strategy, the clinical significance is to, first of all, identify a patient's clinical state as asymptomatic compensated, symptomatic compensated, or symptomatic decompensated. And this is done using clinical diagnostic and imaging measures as previously discussed. Now, after addressing any reversible causes for decompensation, such as hypoxia, hypothermia, selective use of pulmonary hypertension therapies can be used. The more commonly ones are the pulmonary vasodilators, as shown in this image. In the acute phase, this would be one of the two pathways, either the nitric oxide or the prostacyclin pathway. Next important aspect in treating is to maintain sinus rhythm and avoiding or treating any arrhythmias, usual arrhythmias that may occur tachy or bradyarrhythmias. And they should be careful, cautious use of beta blockers or calcium channel blockers because of their negative inotropic effect. One may need to use electrical cardioversion for patients who are unstable and may use transvenous pacing for bradyarrhythmias. Next, it is essential to identify right ventricular failure using imaging modalities, and its specific management will be discussed briefly in the next slide. And lastly, rescue therapies in these patients may be considered using mechanical circulatory support as necessary. I would finally talk about right ventricular failure therapy. Now, once this catastrophic right ventricular failure has ensued, the management is fivefold. Number one is maintaining adequate blood pressure, so to treat systemic hypertension. Two is to treat any reversible cause, which is hypoxia, hypercarbia, acidosis, or even pain or sympathetic stimulation. Number three is volume management. So you don't want to give too much volume. You want to maintain optimal volume because preload is important. Number four is using inotropes. These may include classes such as beta mimetics, phosphodiesterase inhibitors, or calcium sensitizers. And number fifth is using definitive therapy as indicated in patients who have a coronary syndrome or a pulmonary embolism. We will now go back to our three clinical scenarios that my colleague had first introduced and talk about how we would diagnose and manage them. Over to you.
Thank you, Sankalp. We're going to revisit those cases now and bring together everything we have mentioned during this presentation. Going back to the first clinical scenario, that is a patient apparently of a compensated chronic right heart failure. And let's recap. There was a 65-year-old female with osteoarthritis and obesity for elective hip replacement that she presented with bilateral pitting edema. In the preoperative setting, we examined thoroughly her history. She admitted shortness of breath and exertion. From the clinical exam, she did have peripheral edema. We assessed her labs, including ABG and an INR. At that point, we considered PFTs with an EKG and a transthoracic echo. Intraoperatively, we decided to monitor with an EKG and a continuous arterial line. We determined that there would be it would be a good candidate for regional general anesthesia, and we decided on a slow loading of the regional technique or a slow induction, slow controlled induction, where we would avoid tachycardia, would optimize the preload, avoid hypotension, acidosis, hypothermia, and hypoxemia. This patient postoperatively ended up getting transferred to the PACU after a successful procedure with adequate pain control, continuous O2, continuous oxygen treatment, and again, in the postoperative setting, we avoided hypothermia, hypotension, and acidosis. For our clinical scenario 2, this was a patient apparently with decompensated chronic right heart failure. 73-year-old male, history of COPD, presenting the GI unit. He had shortness of breath with minimal exertion, and accidentally received 1 liter of crystalloid after the IV placement. Preoperatively, we did the history review. We did a thorough physical exam and monitored his vital signs. He had shortness of breath, he had jugular venous distension and peripheral edema, as well as hepatomegaly. His labs were significant for elevated liver enzymes, metabolic acidosis, and a prolonged INR. He did not have any changes on the EKG, and we did a bedside transthoracic echo where we identified that he had apparently volume overloaded right ventricle and tricuspid regurgitation. For this reason, the case was cancelled and the patient was transferred to the medical service for optimization. And last case was the case of an acute right heart failure. It's a scenario that we see often. It was a 55-year-old male with angina in the ICU. He had an echo which already showed hypokinesis of the RV, and we knew he had multivessel disease presenting for cabbage. So preoperatively in the ICU setting, we did a TTE and we were able to see tricuspid regurgitation, volume overloaded RV. He had a continuous A line placed, and he already had a central line with a PA catheter for pulmonovascular resistant calculation cardiac output. Intraoperatively, we continued monitoring him with an EKG, arterial line. We did a TE. We had the PA catheter, avoided any hypotension, pain, hypoxemia, acidosis, hypothermia, and excessive PEEP. We tried to limit any tachyarrhythmia, and we were carefully assessing the requirement for fluid versus diuresis and tried to optimize his preload as well as decrease his afterload. The patient required inhaled epoprostenol. We needed to utilize milrinone and vasopressin coming off bypass. And eventually, postoperative, the patient got transferred in the ICU with continued O2 treatment. We continued the same hemodynamic goals. The epoprostenol was continued, and we aimed for early extubation, along with avoiding hypercapnia and acidosis, just to avoid increased PVR.
Well, that was to summarize the perioperative right ventricular dysfunction management, assessment, and discuss some of the anesthetic cases. We hope you guys learned from this and enjoyed, and we're happy to take any questions. Thank you.
Thank you.